Hello friends, greeting from Rfatutors, your mentor this side with the Green Top Guideline discussion for today. Today we are here to tell you about the Management of Breech presentation, the Green Top Guideline 20B, published in March year 2017. Breech presentation occurs in 3 to 4% of term deliveries and is more common preterm. It is associated with uterine and congenital abnormalities, has a significant recurrence risk, and is more common in nulliparous women. The scope is confined to decision-making regarding the route of delivery and choice of various techniques used during delivery. It does not include antenatal or postnatal care. The term babies presenting by the breech have worse outcomes than the cephalic ones, irrespective of the mode of delivery. Remember for your exam. Women with a breech presentation at term should be offered external cephalic version unless there is an absolute contraindication. They should be advised on the risks and benefits of ECV and the implications for the mode of delivery. Women who have a breech presentation at term following an unsuccessful or declined offer of ECV should be counseled on the risks and benefit of a planned vaginal breech delivery versus a planned cesarean section. Women should be informed that planned cesarean section leads to a small reduction in perinatal mortality compared with planned vaginal breech delivery. Any decision to perform a cesarean section needs to be balanced against the potential adverse effects as well. Women should be informed that when planning a delivery for a breech baby, the risk of perinatal mortality is approximately 0.5 per thousand, with cesarean section after 39 weeks of gestation and approximately 2 by 1,000 with planned vaginal breech birth. This compares to approximately 1 per thousand with planned cephalic birth, an important single best answer. Women should be informed that planned vaginal breech birth increases the risk of low APGAR scores and serious short-term complications, but has not been shown to increase the risk of long-term morbidity. Clinicians should care for women in an unbiased way that ensures a proper understanding of the absolute as well as relative risks of the different options. Women should be informed that planned cesarean section for breech presentation at term carries a small increase in immediate complications for the mother compared with planned vaginal birth. They should be informed that maternal complications are least with successful vaginal birth. Planned cesarean section carries a higher risk, but the risk is highest with emergency cesarean section, which is needed in approximately 40% of women planning a vaginal breech birth. Women should be informed that cesarean section increases the risk of complications in future pregnancy, including the risk of opting for vaginal birth after cesarean section, the increased risk of complications at repeat cesarean section, and the risk of an abnormally invasive placenta. Women should be informed that cesarean section has been associated with a small increase in the risk of stillbirth for subsequent babies, although this may not be causal. Following the diagnosis of persistent breech presentation, women should be assessed for risk factors for a poorer outcome in planned vaginal breech birth. Women should be informed that a higher risk planned vaginal breech birth is expected where there are independent indications for cesarean section: hyperextended neck on ultrasound, high estimated fetal weight, low estimated weight, footling presentation, evidence of antenatal fetal compromise as well. An important single best answer for your exam. The presence of a skilled birth attendant is essential for safe vaginal breech birth. Units with limited access to experienced personnel should inform women that vaginal breech birth is likely to be associated with greater risk and offer antenatal referral to a unit where skill levels are experienced greater. If a woman presents with an unplanned vaginal breech labor, management should depend on the stage of the labor. Factors associated with increased complications are found, availability of appropriate clinical expertise, and informed consent. Where time and circumstances they permit, the position of the fetal neck and legs and the fetal weight should be estimated using ultrasound, and the women counseled as with planned vaginal breech birth. They should be informed that induction of labor is not usually recommended. Augmentation of slow progress with oxytocin should only be considered if the contraction frequency is low in the presence of epidural analgesia. Women should be informed that while evidence is lacking, continuous electronic fetal monitoring may lead to improved neonatal outcomes. Birth in a hospital with facilities for immediate cesarean section should be recommended with planned vaginal breech birth, but birth in an operating theater is not routinely recommended. Women should be informed that adherence to a protocol for management reduces the chances of early neonatal morbidity. Adequate descent of the breech in the passive second stage is a prerequisite for encouragement of the active second stage. Either a semi-recumbent or all four positions may be adopted for delivery and should depend on maternal preference and the experience of the attendant. Assistance without traction is required if there is a delay or evidence of poor fetal condition. All obstetricians and midwives should be familiar with the techniques that can be used to assist vaginal breech birth. The choice of maneuvers used, if required to assist with delivery of the breech, should depend on the individual experience, preference of the attending doctor or the midwife. Women should be informed that routine cesarean section for breech presentation in spontaneous preterm labor is not recommended. Women should be informed that cesarean section for breech presentation in spontaneous preterm labor at the threshold of viability 22 to 25 plus 6 weeks of gestation is not routinely recommended. Labor with a preterm breech should be managed as with a term breech, where there's a head entrapment, incisions in the cervix or vertical uterine incision extension may be used with or without autocolysis. Women should be informed that the evidence is limited, but that planned cesarean section for a twin pregnancy where the presenting twin is breech is recommended. Routine emergency cesarean sections for a breech first twin in spontaneous labor, however, is not recommended. The routine cesarean section for breech presentation of a second twin is not recommended in either the term or the preterm births. A simulation equipment should be used to rehearse the skills that are needed during vaginal breech birth by all doctors and midwives. Some important exam points from this green top guideline are the breech mode of delivery, the criteria for the vaginal delivery, and the external cephalic version guideline needs to be done along with this green top guideline. Best of luck from the entire team of Rfatutors. I thank you all for joining us today. See you next time, and until we meet again, take very good care of yourself. Bye-bye.